Good morning and welcome to the first installment of Spartans Step Up, CWRU Community Response to Covid-19. This series is coordinated by the Alumni Association of Case Western Reserve University, and our intention is to share information on the efforts we're making to understand and combat Covid-19. I am Stan Gerson, the incoming Interim School of Medicine Dean, and will do what I can to help direct this conversation. I also am continuing my efforts as the director of the Case Comprehensive Cancer Center. Today we will focus on understanding COVID-19, its spread, its diagnosis, treatment, healing, and prevention. Joining me via Zoom are Dr. Heidi Gullett and Peter Tippett. Dr. Gullett directs the Cuyahoga County Board of Health and is Associate Director of the Case Center for Community Health Integration. Dr. Tippett is a proud double alumnus of Case Western Reserve, graduating in 1981 with a PhD in biochemistry and in 83 with his MD. Dr. Tippett is the founder of careMESH, Inc., a national healthcare provider directory. I would like to thank both Drs. Gullett and Tippett for joining me today on this important topic. I think you'll be blown away by their knowledge. I'll start with Dr. Gullett. Can I ask you to share a little bit about Case Western Reserve University's partnership with the Board of Health and how this relationship positioned you to lead our COVID response?
Absolutely. Thank you so much, Dr. Gerson. I'm really happy to have this opportunity to share our work at the local public health level and also with the School of Medicine today. So back in 2013, Dean Davis created a new position known as the Population Health Liaison position, which essentially embedded me as a School of Medicine faculty member at the Cuyahoga County Board of Health, which is a very large and highly accomplished local health department that leads local health efforts in conjunction with the City of Cleveland Health Department here in the greater Cleveland area. At that time, the intent of the position was to really develop partnerships that would allow us to work together toward achieving equity in our community and improving community health, which, as many of you know, is one of the 3 strategic priorities for the School of Medicine. So I spent the first few years getting really to learn what everybody does here, and then also to think about really creative ways that we could begin to build partnerships across the School of Medicine, other parts of the university, as well as our local health department and other community partners. And that has led us to really exciting opportunities over the last 8 years, really focused on addressing equity in our community and bringing our local hospitals together, as well as lots of other community partners along with the School of Medicine as an anchor for this work. And this positioned us incredibly well for rapid response to the COVID-19 pandemic. So in my role as population health liaison, I had worked to build formal agreements to allow medical students and other students from the School of Medicine to participate in work at the local health department, as well as residents from university hospitals, public health and preventive medicine residency. So we already had this long history of working together on really important community projects. And I also had become the medical director in addition to the population health liaison over the last few years. And so as a result, when the COVID-19 pandemic hit in March, we were able to develop a very comprehensive COVID-19 local public health department response with medical students as one of the cornerstones of our case interviewing, isolation, contact tracing, and quarantine process. I'm happy later during this webinar to talk about, or this town hall, to talk a little bit more about all the elements of our local health department strategy, but I really wanted to highlight the very forward-thinking position that Dr. Davis or Dean Davis created, which then allowed us to pivot very quickly into our medical students being huge partners in this local response and really being an amazing workforce for us.
I wonder if I could continue on, Heidi, and ask just how you're interfacing with case faculty and schools. Here, many of the schools departments and our hospital-based faculty are studying COVID-19 at an accelerated pace. The number of investigators across our community is in the hundreds, which is absolutely remarkable. Your public health COVID-19 information is about as real world as it gets. How does that data inform research efforts across CWRU that are related to COVID-19?
Yeah, it's a great question. So, what I view in my liaison role with the School of Medicine and with the university in the larger view is really to think about how we bring the on the ground local public health perspective to investigators, partners in the community and at the School of Medicine and across the university who can really translate new knowledge very quickly in a rapidly evolving pandemic that actually improves the lives of our residents and our state and our nation. And so that's come a few different ways. One is that we are able to really bring in faculty members. We have a number of School of Medicine faculty members who are intimately involved in the response here and who are actually case calling. Actually, a group of them are out doing swabbing right now in one of our homeless shelters. And that deep knowledge of on the ground response has enabled us to write a number of grants in the recent weeks, sometimes in the middle of the night because there's no other time, but that's really informing thinking about research efforts around COVID-19. We're very careful around data protections, as you know, and we don't just freely share any data that comes through public health. There are research protections that we have in place, but this has enabled us to really be proactive in identifying areas of research that are really critical in the moment, right just in time as this evolves. One example is that very early in this response in March, we started to recognize the number of pregnant women who were testing positive or who were what we think are probable cases. They couldn't access testing, but they had an epidemiologic link to lab confirmed cases. And we were able to rapidly pull together a team across our different hospital systems to deploy a research study to figure out how transmission and understanding of immune response in pregnancy happens. And so that's ongoing. But that's one example of how using this role and all of the knowledge we're gaining at the public health level really can translate into other research advances that really help all of us get through this a little quicker.
And that's terrific, Heidi. I want to thank you for those perceptive comments and the incredible effort that you're making on the part of the city and the community. I'd like now to turn to Dr. Tippett. You come at this from a very different angle, but with just as much passion. Tell us a little bit about your company and how your work actually relates to this specific pandemic.
Well, thank you, Stan, and nice to meet everybody today. I started a company called careMESH, and it was organized around the sort of problem that doctors really can only talk to other doctors outside of their own organization over the telephone. We really don't have the equivalent of email or other data sharing capabilities outside of our own organizations. Within our organizations, our EHR generally does a pretty good job of making it possible for us to share a message or a question with another staff member or doctor to help coordinate care with our patient. But when you try and coordinate with that outside doctor in the community or the one that's in the next county, getting a message to them winds up being fax 76 or 7% of the time and phone calls the rest of the time. And the ability to make it digital has been a goal for decades now, and it's been more or less an abysmal failure. So careMESH was born to solve that global or national interoperability problem, make it possible for any hospital or any doctor to communicate with any other and share a medical record with any other without having to worry about whether the other guy had a particular electronic medical record or particular technology. Just like FedEx, give them the package and they'll deliver it to your mom. Whether she's on an island or not is their problem. So that was the idea for careMESH. How it ties to COVID was that when you get down to it, coordinating care or dealing with track and trace or test and trace or figuring out how to deal with people popping up with a brand new disease scattered all around really requires not just testing, but also communication and getting the data to the public health departments, getting the data from the doctor's office so that you could do the epidemiologic study to figure out whether pregnancy mattered or not, or whether smoking mattered or not, or whether hypertension or a particular medication mattered or not, really requires pulling together the data from the people who care for the patient outside of COVID and for the immediate question that's at hand when you test positive. And so careMESH has offered our directory, which is of all clinicians and all health workers in the country, free for all public health departments. And we've also trying to figure out how to make it easier for everyday people in the public health world and in the clinical world to communicate more or less instantly by bringing whole regions or states on board sort of in a week or so.
Thank you, Peter. You authored a LinkedIn post, Saving Your Health One Mask at a Time. I'll say that again so people can look it up. Saving Your Health One Mask at a Time, which has received considerable traction. Congratulations, because it was a very thoughtful piece. As someone with a strong medical background and your commitment to meshing together all these data sources, how can you give some advice to our CWRU audience and our fellow alumni about preventive efforts during this COVID-19 pandemic? What have you learned?
Yeah, this post I wrote at the end of March. I, like all of us in the medical world, kept reading Idiocy, and my neighbor, my actual next door neighbor, asked me if it was okay for him to floss his teeth. He told me when he was walking his dog out in the countryside that he came back, took all his clothes off, and took a shower, and that he washed his hands 20, 30 times a day while in his house. And there's all kinds of people who are presenting all these kind of, well, why don't you worry about the problem where the problem is and not worry about where it isn't? And so I felt compelled, with lots and lots of different input from random people and patients and others, to sort of figure out how to tell regular lay people when and how to worry, not whether, we just do the wash your hands and wear a mask or keep a distance and wash your hands. And that's just not enough. The when and where and why needed to come out. So I sat down one weekend night and just wrote this thing, Saving Your Health. If you want to Google it, it's past 2 million readers. It's 10 pages, single-space text. And to have many millions of people not just download it, but read it end to end, and it blows me away, completely blows me away. There's another one I'll give credence to that came out a couple of days ago from Aaron Bromage, Bromage, called The Risks, Know Them, and Avoid Them. Dr. Bromage's paper and mine are incredibly complementary. If you want to read one or the other, they're very helpful together. Dr. Bromage is about case histories and the events that actually we know so far that led to big bursts of problems. But the idea of the LinkedIn, I didn't have a better place to stick it. Luckily, it's available for everyone. But the idea of the paper was just to make something available for regular folks to understand what I now call a safe zone. Your home, your yard is typically a safe zone. You don't need to wash your hands 40 times a day at home. The regular amount is okay, right? You don't need to wear a mask at home. But when you go out into a caution zone or a danger zone like shopping or to work, that's when you need to keep your distance, wear a mask, wash your hands when you get back to your safe zone, and give people sort of rules of thumb and and how do viruses work? What do you do with the package that winds up on your front desk? The front stoop, should it be worrisome or not? And those sort of everyday sort of questions. That was the idea of that, and it's blossomed into thousands of questions and all kinds of scenarios that, I feel like writing a book now.
Thank you. I appreciate those comments. And I think it's certainly given us pause about the importance of biomedical practice as well as biomedical research. I'm going to now move on to some of the questions that our alumni participating this morning are addressing for both of you. Let me ask Heidi and then Peter about advice. As we know, the world's opening back up a little bit, although we've been cautioned. What advice would you give to someone who's now, for the first time in maybe 6 to 8 weeks, actually going back to work? Heidi?
Yes, it's a great question. So in our COVID response here at the local health department, we have well over 2,000 lab confirmed cases and probable cases, and we've done nearly 4,000 contact interviews. And so we continue to have these conversations on a one-on-one basis through our case identification and contact tracing process, because many of the people we've been talking with were essential workers and have been having to go out to work because we needed to keep our workforce going, even for some of these folks who've been exposed. And so we've been having these very careful conversations about how to protect yourself, but now it's opening up to the rest of the community, and more people are returning to work this week in Ohio and elsewhere. And so I think it's really important to be thoughtful, as Peter so eloquently discussed in his writing, as well as in his talk a few minutes ago, is to be thoughtful about where this virus is and not to be consumed by fear, but to have a healthy sense of concern where it's appropriate. And so we know that interactions with other individuals continue to perpetuate new elements of transmission in our community. Just this week and last week, we're seeing gatherings of birthday parties, gatherings for other celebrations. We're seeing people playing cards together. We're seeing people gathering for other social events, and they're all positive now. And so we need to understand that social distancing works, and that even though you may have family members or coworkers that you are social distancing from at work or wearing a mask appropriately, if you hop in the car with them, take your mask off and spend some time together without those social distancing measures, or without wearing a mask, or without hand washing when appropriate, without cleaning frequently touched surfaces, transmission will occur. And so we really got to think about it as, I have it and I need to protect everybody else from getting it from me. And I think that's a good rule of thumb. But certainly there are lots of different scenarios, as Peter points out, that we get asked about, what if this, what if that? And we do our best to do general education, but then there are always these small caveats to these things, and we have to think through them. But the general advice is there, and you really do have to recognize that transmission continues to happen in our community and thousands of other communities across the country. And we've got to do, every single person has a part to play in reducing that transmission, getting us through this. It's not just enough to flatten the curve, because if we have another risk of a surge when we don't do those social distancing and other mitigation efforts that we personally have control over.
So Peter, I'm sure you have thoughts on that, as well as what our outlook is. What's your sense of just how long social distancing is going to be required?
Yeah, let me take that in two quick parts. I'd answer your first question
Please.
By saying that people should read both my paper and Aaron's paper. The Saving Your Health One Mask at a Time is a good Google search, and Aaron Bromage is the other, Bromage. Those are very full of great advice. I am lately in a twist over the constant press drumbeat that there's something wrong with masks. This isn't a red-blue drumbeat. This is, it's very common, including the CDC and New York Times and Washington Post, certainly, saying things like, masks generally protect other people from the person wearing the face covering, rather than preventing the individual who is wearing the face covering. This is, I'm reading this from a paper, a national paper from yesterday. Mask, I think we ought to be selfish, protect ourselves. I think we ought to think of masks as the things that help us save ourselves from getting infected. And if you think of it that way, then they might incidentally save somebody else too, and that's a good thing. That's altruistic. But people tend to be a little more organized around protecting themselves and their families. So let's embrace that. Wearing a mask and social distancing and testing are the seatbelts, airbags, and traffic laws of the new world. You need more than one thing. If you wore a mask in a densely populated restaurant with hardly any circulation, or a workplace, with poor circulation. 30-40% of people among 70 people in a work zone sitting there all day long, wearing masks or not, might well get that virus because of the fog that might persist forever, and your multiple breaths of 70, 80, 90% reduced viral load still might be enough to get you infected. So you need more than one control at the same time. I'll stop there.
And your sense is that this is going to be with us for a long time.
Yeah. I think all of us kind of get our sense for whether, what ends this in the long run is some combination of vaccine or, herd immunity. Nationwide, we're in the 2-3% range maybe of people who've been infected. In the biggest, most infected, most dense place we've got, New York, we're in the 21 or 2% range of people who've become infected. Herd immunity doesn't kick in until we're in the 70 or 80% range. It certainly doesn't help those 30% who are not immune if the rest of the world is also pumping disease at us. So we've got a long way to go before we can year plus time frame before we can start behaving in other sorts of ways. But figuring out how to be simplistic and wear a mask all the time when you're in a danger or caution zone, and be free of it when you're at home or walking in the woods or taking a bike ride. To the extent that we can get comfortable with how to behave the way we are comfortable in a car, putting on a seatbelt and getting on with it, is the sort of thing that we're just going to have to make work everywhere. By the way, if other people are interested, I'm trying to get folks agreeing with my case that masks are good for you, not just for the other guy. And I'm likely to put together a poll of doctors or scientists that are interested in supporting a sort of a vote like that. You often see a bunch of lawyers or whatnot getting together saying, we support the following notion. Send me an email at peter@caremesh.com. I'm looking for a group of doctors or scientists that are willing to support. I'll write some kind of paper and submit it with a bunch of signatures that we can maybe get the big media to at least agree that masks are good for both purposes, not just protecting the other guy.
Thank you, Peter. Heidi, I wonder if you can be as clairvoyant as you can with all of the activity around vaccine development. Do you have a sense? What are you explaining to your community, to your patients? When will a vaccine show up?
Yeah, it's a great question, Stan. So, that's unclear. We do know that we've had record movement toward the phases of trials that we currently have compared with prior vaccines and vaccine responses. But I think it's still unclear to us exactly when that'll happen. I suspect it'll be in the next 12 to 18 months when we'll see stuff actually filter down to our level here at the local community. What we're saying to folks is at this point, we need to be very aggressive about testing. We need to really be focused on active infection, testing for active infection, viral testing at this point. There are a lot of tests that are under emergency authorization, different ways of collecting tests, but right now we're focused on nasopharyngeal testing, using PCR to determine that there is an active viral infection. And at this point, we're doing a little bit with serologies and looking at seroprevalence, meaning looking at the level of potential immunity among some people in the community. But we certainly don't know that the serologies we have available right now indicate anything about future immunity. And so we've really got to focus on vaccine, but we have been so behind on testing right now that understanding the true prevalence of this in our community and thousands of other communities across the nation hasn't been possible given limited testing. So my focus has really been a narrative and messaging around the value of testing and using an equity-based strategy to get testing to those in our community who have not been able to access it, but who really are the highest priority for testing. And then at the same time messaging that a vaccine is coming. When it comes, we will be ready to administer it in high volume. We do what are called pods in local public health, points of dispensing. And we're using that as a strategy for community-based testing out in neighborhoods. That's sort of the prototype we're using. And our messaging is that when the vaccine's available, we'll be back to the same locations and we'll be getting this out as quickly as we can. But right now we've got to test you so we can isolate, we can contact trace, and we can quarantine when people have been exposed. And that's really our key messaging. I really want folks to understand that we are in the fundamentals of public health in order to get through this. And the vaccine's really the back end of primary prevention, but we can't get there for a while. We have to do what we have in front of us and available to us.
I wonder if I could go on to your perception as a practicing physician, Heidi, on why you're seeing patients with no symptoms, mild symptoms, and severe symptoms. Do you have a perspective, and how do you advise that COVID positive individual?
That's a great question as well. So this is an incredibly curious virus. From a physician standpoint, our team here has done over 2,000 case interviews of like I said before, lab confirmed and probable cases. And so in early March, right after the first cases, of course, in Ohio, we had the first cases here in our jurisdiction. And so we early on did a ton of interviews before other jurisdictions. And we realized the value of syndromic surveillance, basically understanding what symptoms were happening. And what we learned very quickly is very few people were hospitalized initially in their hospital course or in their disease course. They were having all kinds of other symptoms that hadn't really been publicly identified. And so we became very adept early on at collecting all of those symptoms and the time frame of those symptoms. And that allowed us to be much better at identifying people who were actually symptomatic and didn't realize it. And early on, there were a large number of healthcare workers who were working with those symptoms because they didn't recognize those were COVID. They thought, I've got allergies, it's kind of allergy season, or I've got, influenza was really circulating here a lot right as COVID hit strong in March. Maybe that's it. There were a lot of those pieces. And so we're much better able to give employers and patients a much better understanding of what this looks like and how they can protect themselves and they can protect other people as they get these mild symptoms. But that was that took a little bit of time to develop and come on. So we're continuing to do syndromic surveillance because now we're seeing that people do have decompensation in the second week and they have children. We have a lot of positive children that have a syndrome that you're hearing about nationally that wasn't identified earlier. And we certainly have concern that exists in our local community or at least in our state. So those are some of the things that as a practicing physician, I'm trying to identify so that I can better equip primary care docs out in the community, who are the vast majority of people are contacting primary care docs. They're not really interfacing with intensivists or pulmonologists until they're really sick. So we've got to make sure that our primary care community is educated about how to support people. We also set up a 24/7 physician line here at the Board of Health that's staffed by public health preventive medicine docs, most of whom also have other board certifications in clinical specialties, that allowed us to be able to guide people through their syndrome and their experience of infection, because people are really scared. And these symptoms can be really overwhelming, particularly the sense of shortness of breath. And we see that there are a lot of asymptomatic people as well, or people with hypoxia who really have no other symptoms. And that's pretty darn scary. So we're really learning as we go, but trying to be as evidence-based about the guidance we give people, including our fellow physicians in the community. The other thing I'll say is that we haven't detected as much asymptomatic infection as other places have. And part of that has been our testing limitations. We haven't had enough testing capacity to test broadly. So we haven't actually been able to get asymptomatic people tested as much. In recent weeks, we have been able to do that for those who work in congregate settings. So either reside in or employed in congregate settings like nursing homes and group homes, correctional facilities, homeless shelters. And in those facilities, we have found asymptomatic infection. And so it's been really trying to figure out how we isolate those folks. What do we do? How do we explain isolation? They don't feel sick, so don't feel like they need to be at home, but really giving good guidance about what you need to do in the home. Our Army of Medical students here is magnificent at explaining infection control practices, isolation, and quarantine, helping people understand what that means inside their home, but then helping them identify resources that allow them to isolate and quarantine safely. And that sometimes means that we contact our sanitarians to pick up medicines and deliver groceries and cleaning supplies. So very, very pragmatic, but that gives you, it's a bit of a long answer, but kind of gives you a glimpse into what we do day in and day out, and really trying to get the right message to the clinicians and people who are affected by COVID-19 through infection.
Thank you. So I have one final question for each of you. For Heidi, after people you would think have recovered, what are the long-term effects you're seeing in the COVID-positive patient population?
Yeah, well, even though this does seem like we've been at this for years, it's really only been a couple months. So our earliest clearance of cases has only been a couple months that they've been through this. Really just our first cases really cleared about 6 weeks ago or so. So we really don't know. What we are seeing, and we're always scanning literature from other parts of the world and other parts of the country who are a few weeks or a month or two ahead of us. But we're very aggressive about understanding how this is playing out in our local community and our local context. So I hope I can answer that question more fully in the coming months and years. But what we do know is that people who have cleared, meaning we've discontinued them from isolation, it doesn't mean that they don't test positive still. And that's a misconception in the community. A lot of people think, well, if I still test positive, I must be shedding virus. And if I do test positive, I'm not through this. And that's not really the case. I think you were asking more about what are they experiencing. And we certainly have had people who've been experiencing cough and shortness of breath and other symptoms for weeks and weeks and weeks at a time. Others, again, are asymptomatic or have a mild nasal congestion and they're gone and they are much better. It's very hard to predict who those people are. I mean, obviously people with underlying comorbidities do have higher risk of hospitalization in ICU, and I analyze our data weekly to present to the press. I see that. But then there are also people without any of that are quite sick. But the vast majority of folks in our community are hanging out at home with these symptoms, and some of them are really hanging on for quite a while. So I think that remains to be seen, but there's a lot of confusion about whether people should be retested, and we don't have testing capacity at this time to be retesting everyone to clear them from infection. That's very different than the guidance that the CDC put out early on in February and March. But I think at this point, it's reasonable guidance based on what we have from larger studies out of other countries.
Thank you. And then Peter, we're hoping that the sun will take this thing away from us, although most of us doubt that. You think we're going to see a surge this fall and this winter? Is it going to overlap with the routine influenza? What do you think is going to happen this summer and fall?
Yeah, I do think there will be, I'm not sure what the timing will be, but with so few people immune, the chance, and with so much laxity in our interactions around the country, I can't imagine any other outcome other than another increase. I just don't see it. It'll be a while before people can internalize what works and what doesn't from seeing their neighbors and seeing the case on the news and seeing the stories and getting the feeling for how to behave. And we don't have the same sorts of strong, we don't have a dictatorship that can go and rip people from their families and stick them into another home. One other thing is that people talk about this row zero, the number of infections that are likely to come from a single person who's infected in the first wave. We all know it's an exponential process of infection, but what the exponent is the big question, whether it's 2, 4, 8, 16 people get infected as one person spreads or more or less than that. In America, 2.5 people live per household on average. In the big cities, it's more like 3.5 people per household. And when you come home from wherever you got COVID, the most likely thing you're going to do is infect those people in your house, right? Even our CNN anchor, who got COVID, lived in the basement, had an apartment, had his own shower and kitchen and everything, and 15 feet away in what would boil down to a different building, his wife still got it. So keeping your your housemates from getting infected is really, really, really hard. And we just don't have any appetite for separating either the sick away or the well away. And all by itself, that's going to keep our multiplier higher than it might be somewhere else. So when we get these pods of infections, whether they come from a workplace or a restaurant place or a church choir or whatever it is, and they wind up with 10 or 20 people infected, they're likely to go out and infect 3 or 4 others just because of the nature of the way we typically behave. So yes, I can't imagine that we won't have significant increases in places where we haven't seen it before. And a bumpy rise scattered all around the country. I'm not sure that the flu season will make it worse or not. That's up. We'll see that coming. I do have a lot of hope for treatments, and to the extent that we can do prevention through masks and distance and testing and separation and whatnot. Treatments, of course, will help keep people sick for shorter periods of time and with less morbidity and mortality. So hopefully we can get some of those piled on and get some, and those might happen a lot faster.
So thank you, Peter. I'd like to thank Drs. Gullett and Tippett for their incredible, accurate insight. It's been incredibly helpful for all of us to get some information that's timely and thoughtful. I want to also mention that at Case Western, across all the disciplines you can imagine of the university, we have a task force, which I mentioned, has over 200 scientists, investigators, academicians that are looking at issues of the ethics, the science, the biology of the vaccine, the issues of treatment, precautions, safety, therapeutics. We have a number of new drugs, a number of cell therapeutics. I found out just yesterday, for instance, that a cell therapy that developed in our own laboratory facility here at Case had been shipped off to the University of Indiana and successfully treated 4 patients. So we are in the middle of this hurricane, and we're the eye of the storm in terms of coming up with better approaches and therapeutics and understanding the biology. There's so much we don't really understand about this. All of us are very hungry for information during this ever-changing response to the pandemic, and we're doing everything we can to help participate in preventing its spread. We're also undergoing active discussion about how to make it safe to be at Case Western on the campus this summer and fall. The Alumni Association of CWRU will have future episodes of Spartan Step Up that will focus in other ways that COVID-19 is affecting our community. These episodes will feature my fellow faculty members as well as CWRU staff and alumni. Please be on lookout for these as they occur over the spring and summer. We thank you for joining us today, and we wish you all good health. Thank you. Bye for now.
Thank you.
Thank you.